Hello, we can't hear you.
Hello, we can't hear you.
We can hear you, sir. Yes.
Yes. Now I can hear you.
We were not speaking for a while.
Oh, yes.
No one was speaking. Everyone was quiet.
Oh, hello. I thought you will be starting it.
Amit, we are live right now. Amit, we are live right now.
Yes, sir. So in a minute or so, we will start. So it's 2:08. We are about 130 people on live. Do we begin? Dr. Saurabh and Dr. Manoj?
Professor
Yeah,
Baku,
please.
maybe you need to put your audio off, Professor Baku.
Audio off.
Yeah, off till we, so each of us will put our audio off till it's our turn to speak.
Amit, let's start.
Yes, sir. So welcome everybody. Very good evening to all of you, to all our panelists here and all the participants who have joined us. I would first like to welcome our senior most member, teacher of teachers, Professor Owen Bakku, sir, who is our chief guest today for this the journey of Journal Club, which NNF is starting. It's a very academic program. It's a new beginning for NNF. And so we are all very pleased to have this program under leadership of Dr. V.C. Manoj, our NNF president, and chairmanship of Dr. Saurabh Datta, who is the research committee chairperson, and coordinator Dr. Professor Ramesh Agarwal from AIMS. And we have our journal editor, Dr. Somshekhar Nimalkar over here. And welcome, Dr. Somshekhar. And Professor Wali Carlo, whom we all have known for a long period, whose books and articles on ventilation we have studied as students and still continue to read. He is the lead author of this wonderful paper. Welcome, Professor Wali Carlo. And so this is the first, and we will have a monthly session of journal clubs in which there will be one presenter and with moderator and an expert. And we will try to have the lead author like we have today, Wali Carlo sir, with us, so that we can, have the nitty-gritties of the trials or any questions which the people may have, or any controversial issues in that paper, which we can discuss with all of them. So with this, I would go on to Dr. V.C. Manoj sir, our president, to welcome us all and tell us about this program a little bit.
Thank you, Amit. Hello, everyone. Good evening and good morning to Professor Wali Carlo. Hearty welcome. It is with immense pride and purpose that we gather today to mark the inaugural session of this novel initiative, NNF National Journal Club, a milestone in our continuing journey towards excellence and neonatal healthcare. In this era where actually medicine moves at an unprecedented pace, staying rooted in evidence-based practice, especially in our resource-limited settings, is not only just desirable, it's indispensable. We move on to precision medicine in the future. And until we have our basics right, we can go wrong in so many ways. Through this Journal Club initiative of NNF, under the chairmanship of Professor Saurabh Datta, we aim to create a vibrant ecosystem where clinical insights are examined with rigor. Research is translated to practice. Let's try for that. And every discussion strengthens our collective resolve to do better, be better, and serve better, and bridge the gap between science and our neonatal practice. We have today a true legend of neonatology, Professor Wali Carlo from US, and a doyen of neonatology from our country, Dr. Bakku, along with distinguished faculty from our country like Professor Saurabh Datta and Professor Ramesh Agarwal to lead the discussions. Hearty welcomes, sirs, to this session. I also welcome all of you and invite each of you to engage with these experts, challenge assumptions that we used to have with respect and academic integrity. Let this space, Journal Club, be a space where we refine not just our knowledge, but our convictions. We work in resource limited settings and we have heterogeneous levels of care in our country. Until the evidence-based medicine principles are and the advances are percolated down to the areas which are unreached, we are not going to improve as a nation. Friends, together, let's resolve to sharpen our knowledge and skills with the compassion that every neonatologist should have while trying to reach the unreached and our tiny babies. Thank you, and let us begin our journal club. Thank you.
Amit, you are muted.
Amit, you're muted.
Yes, sir. Yes, sir. Thank you, Dr. Manoj. Welcome, Dr. Lalan, sir, our President-elect NNF. Nice to have you here. We'll have word from you in between as well.
Thank you. Thank
I
you.
would now like to invite the Chairman of Research Committee, Dr. Saurabh Datta, sir, to please tell us about what this journal club would be all about and how would we go about it in coming times.
Thank you very much, Amit, for that kind introduction. Firstly, I think if it were not for the infectious enthusiasm of Amit, this journal club would probably not have seen the light of day. He was the driving force, although it was the Neonatal Research Committee where this idea first came up. And I must acknowledge all the members of the National Neonatology Forum Research Committee for their contributions. And I'll just read out their names. They are Dr. Pratima Anand, Dr. Deepak Chawla, Dr. Mangala Bharti, Dr. Naveen Jain, Dr. Ramesh Agarwal, Dr. Sindhu Sivanandan, and Dr. Veera Raghavan. They're all stalwarts in the field of neonatal research in India, and I'm really blessed to have them as part of my committee. I must make a special mention of Dr. Pratima Anand, who really helped a lot with a lot of the organizational part of this journal club, and Dr. Ramesh Agarwal, who very kindly agreed to host the first journal club. So the whole idea of this journal club is that we're going to make it a monthly exercise on the last Thursday of every month at 8 p.m. So it's going to be a fixed, day of the week and time, so that everyone knows beforehand. The link for joining the journal club will be the same every time. We are going to have one host institution from different zones of the country by rotation every time. So the local faculty member in the host institution would identify a student from that institution who would present the journal club. And with the help of one external expert, either a member of the research committee or some invited expert, from a group of shortlisted articles, we would select one article for discussion in that journal club. The article would be of relevance to our Indian context and would be something that would be applicable to all levels of care in India. So we would take care of that. And by rotation, we would have different types of study designs taken up. So this time we have started off with a randomized control trial. Sometimes it will be an observational study, sometimes a diagnostic test study, sometimes a meta-analysis, and so on, so that we are able to cover critical appraisals of various kinds of study designs over the course of time. We have in fact already sort of earmarked where the next journal club is going to be, and we'll probably announce it towards the end of this session. Having said all this, it gives me great pleasure to introduce to all of you my mentor, my teacher, my guru, Professor O.N. Bhaku. He was one of the founding members of the National Neonatology Forum and a father figure in the field of neonatology. He was the head of the neonatology unit at PGIMER Chandigarh, which had started the first DM program in the country. And he has been a mentor and an iconic figure in the field of neonatology, has inspired generations of pediatricians and neonatologists in India. With that, I would request Professor Bhaku to kindly unmute his microphone and give us a few words of inspiration.
Well, thank you very much, Saurabh, Dr. Manoj, Dr. Amit Upadhyay, Dr. Saurabh Datta, and friends. I am really grateful to the organizers for inviting me to participate in this inaugural session. I congratulate NNF for starting this online monthly journal club as a part of its research committee activities. I think the idea has been really very great to have a national journal club, which I think will give us newer insights into our views on evidence-based medicine. The concept of journal club has existed ever since my residency days, that is for over 35 years now, but was restricted to the local institutions. The current online journal club will have very wide participation from all over the country and abroad, and it will help. It will also help train our fellows in understanding the research planning and research data analysis with special reference to biostatistics, as well as its role in evidence-based medicine. I understand this journal club will also provide mentorship by the experts for the beginners, which will be of great help. To conclude, I suggest that we should preserve a summary of each session for future reference. I thank Professor Saurabh Datta for making me aware of this meeting. Thank you very much, everybody.
Thank you. I hand it back to Amit to continue the session.
Thank you, sir. So wonderful words from a teacher of my teachers. So thank you very much, sir. And it's very nice to see you so healthy and so active and clear in your thoughts as you were 30 years ago. And with your words, now we move on to the presenter team led by Professor Ramesh Agarwal from AIMS, New Delhi. So Professor Ramesh is an avid researcher on top of a very astute clinician. And so this combination of being a good clinician, a compassionate clinician to astute researcher is very rare these days. So with all these attributes, I invite Dr. Ramesh Agarwal to please tell us about this wonderful article of extended caffeine for apnea in moderate preterms, the Mocha randomized clinical trial, which was published in JAMA on April 28th in 2025. Dr. Ramesh, are you here?
Yeah, I'm here. Thank you, Amit, and everyone. There are 257 participants coming from different parts of the country. So that underscores the faith that the pediatric and neonatology community is reposing in NNF, and that's really wonderful. And that also underscores the high expectations that they have from us and the deliverables that we need to make. So the article that we are going to discuss is the extended caffeine for apnea in moderately preterm infants. Mocha or Mocha trial, whatever it is, Woli would be able to let us know better. The article has been published in JAMA in April 2025 issue. Absolutely a fresh article. Published by Neonatal Research Network of National Institute of Child Health and Human Development of USA. For the participants, NRN is a network of approximately 20 odd leading centers of the USA, established way back in 1986 to fill the gap that existed at the time, that a lot of things were being done without any evidence. And NICST realized that gap and rightly constituted NRN. And in last 40 years, the contributions, I would say, of the NRN have been simply immense. And, a lot of evidence, pieces of evidence have come from NRN and changed our practice in more than the way that we realize. The study was led by Professor Waldemar Carlo. We call him Wally Carlo. I would say, he's truly an astute clinician and a deep researcher with passion. This is how I would describe him. And Wally, as we lovely call him, we talked about it, and it felt so nice that you remember hours that we spent together, sitting in Professor Vinod Paul's office and discussing things at length. And unfortunately, I could not accept being a fellow in your unit, your kind invitation. Wally came at that time for teaching ventilation workshops. A ventilation workshop, we used to do it quite often. And I said, astute clinician. And, one thing that I only repeated for maybe almost once in every week on my rounds, that how do you judge the adequacy of I time and E time clinically? Graphics can still fail, but that observation that the chest rises and stays there for a fraction of a second, and it falls, and then before rising again, it it stays there for a moment. That means your I time and E time are adequate. And I must have taught it 1,000 times. Last 25 years, I can't remember it how many times. So thank you very much for being that passionate teacher. And there is something special about teacher of your generation. I will not go in detail. I can say a lot about you. A passionate researcher, not only trials and observational studies in the US, but also he has been a very important part of global network for women's and children's health research, and conducted many studies, trials that shaped practices in the developing countries, including India. The current study caffeine for apnea of maturity, though setting is slightly different, as in that they are talking about babies that will be discharged at around 36-37 weeks of gestation. We have been sending babies a little early, but the idea is very important. The idea is that you have a baby who has passed through the acute stage, now staying in the hospital before he can become fit to get discharged to home. And then there are several issues, the apnea, which may have resolved by now. So to continue caffeine therapy or not to continue therapy, feeding adequacy, temperature stability, and family's competence, etc. So there are several issues that is keeping the baby in the hospital. And we carry the idea that because you stop caffeine and then wait for 6 days, so that part might be contributing significantly to the hospital stay. So what if we continued caffeine for longer period until a time when the baby is for sure have resolution of apnea of prematurity, thereby can we reduce the hospital stay? So in a country which has got 26 million babies, with almost 4 million babies requiring admission every year, this issue couldn't have been more relevant. The presentation would be made by Dr. Harshita Nori. She's a bright DM resident in our unit. Harshita, over to you for the presentation. In next 30 to 35 minutes, you would make presentation, and then we will get back to Wally for his comments. Over
About
to you.
25 minutes you have, Dr. Harshita, to present it.
Yes, sir. Thank
Yes.
you, sir.
5 minutes before 25, we will give you a reminder.
A very good evening to respected faculty and my dear colleagues. I will begin my presentation without any further ado. In the course of this presentation, I would like to introduce the background of the studies for today's journal club. I will discuss in brief regarding the methods and methodology of the study. I will introduce the terms randomization, allocation, concealment, and blinding. And I will go on to discuss the results of the study and finally, in the end, appraise the article. So coming to the background of the study, apnea of prematurity is a common disorder in babies born less than 34 weeks of gestation. And the time to resolution of apneas is inversely related to the gestational age. In babies born at less than 26 weeks, apneas have been seen occurring even up to 44 weeks of postmenstrual age. And therefore, apnea seems to be a common cause of prolonged stay in these babies. And caffeine therapy has been proven to be the drug of choice for apneas. So with this background, we will look at a patient whom we had recently treated. So this was a 29-weeker, 1.1 kg male baby who was born by LSCS. The baby had a smooth perinatal transition and he was stabilized on CPAP after birth. He developed apneas on day 4 of life, for which caffeine therapy was instituted. The baby subsequently continued to have occasional odd episodes of apnea, and he was made off CPAP at a postmenstrual age of 34 weeks, and subsequently caffeine was stopped at 35 weeks. This baby was transitioned to the mother's side on spoon feeds. However, on the 4th day after cessation of caffeine therapy, he had a recurrence of apnea with cyanosis, and caffeine was restarted. Subsequently, caffeine was continued for another week and then stopped after the baby did not have a recurrence of apnea, and the baby was further observed for another 5 days before he could be successfully discharged home. So we had 2 issues in the treatment of this baby. One was that he had a recurrence of apnea, which could have been potentially fatal. And also, because of the reinstitution of caffeine therapy and waiting for after stopping caffeine, the baby had a prolonged hospital stay. So, in this baby, should we have continued caffeine when we had shifted him out of NICU? And also, if in that case, how long do we give caffeine for? So that forms the premise of our study, the extended caffeine for apnea in moderately preterm infants, the Mocha randomized controlled trial. The primary hypothesis of the study is that in preterm neonates with resolved apnea of prematurity, continuing caffeine treatment will reduce the number of days of hospitalization from randomization to discharge up to 48 weeks of postmenstrual age. The secondary hypothesis was that continuation of caffeine in these babies would reduce hospital readmissions and would also probably reduce sick visits to the emergency department. So coming to the methods and methodology, the study was a multi-center randomized placebo-controlled trial with a parallel enrollment and a 1:1 allocation in each of the treatment and control arms. It was conducted in 29 hospitals of the United States under the NICHD NRN registry. Ethical approval was obtained from the institutional review boards at each of the centers and at the Research Triangle Institute International. Babies who were born between 29 to 33 weeks of gestation were randomized in the trial at a postmenstrual age of 33 to 35 weeks when they were planned to stop caffeine, provided they were on enteral feeds of greater than or equal to 120 ml per kg per day, and there was a feasibility to start the study medication within 72 hours after stopping caffeine. However, babies were excluded if they were receiving any form of respiratory therapy, if they were being discharged on an apnea monitor or if parents requested for an apnea monitor, if the baby had a congenital heart disease except for an ASD, VSD or a PDA, if the baby had a neuromuscular condition which affected respiration, any major congenital malformation and or a genetic disorder, or if the baby was being planned to be transferred to a non-NRN site before discharge. Central randomization was done in the trial with stratification by center and gestational age, that is 2 gestational age groups of 29 to 30 weeks and 31 to 33 weeks. Babies who were born of multiple births were randomized separately. Allocation concealment was also done through central randomization. All the research staff, healthcare staff, outcome assessors, and family members were masked to the treatment allocation except for the study pharmacists. So before I introduce the terms of randomization, allocation, concealment, and blinding, it is important to know that all these 3 terms are not synonymous. I would like to show you how the usual flow of patients in a randomized control trial. Say, this is a group of participants whom we want to assess for inclusion in our study. Now, these patients are assessed for eligibility based on inclusion and exclusion criteria, which are pre-specified before the onset of the trial. Once the patients meet the eligibility criteria, they are said to be the eligible population, and now they are randomized into either the intervention or the control arms. Participants in the intervention arm would receive the intervention along with the standard of care, whereas participants in the control arm would receive the standard of care with or without a placebo. Both the groups of patients would then be followed up and the outcomes would be assessed at the end of the study. So now, at the point of entry of the patient into the trial, if there is any form of unfair allocation of the patients to either the intervention or the control arm based on either the patient characteristics or the disease characteristics, it could result in inappropriate results. This is known as selection bias. Alternatively, if a treating physician or a trial investigator has a priori knowledge of the patient allocation, they can probably provide differential treatment to the sicker patients, and this can alter outcomes. And this is known as performance bias. In the end, if a trial investigator has a knowledge of the treatment which has been provided to the participant, they can differentially assess the outcomes in the patient, again altering the results, which is known as ascertainment bias. Hence, randomization, allocation concealment, and blinding are important design aspects which will help in preventing these different forms of bias. So what does randomization mean? It refers to allocating participants in a study to different arms in an absolutely random manner. The purpose of randomization is that each patient has an equal chance of either entering the intervention or the placebo arm at the start of the study. By randomizing, we produce comparable groups who are similar in all important aspects except for the intervention. Now, there are 3 important components of randomization, namely generating a random sequence, allocation concealment, and implementation of the randomization. So by randomizing, we eliminate the selection bias and we balance the groups with respect to many known and unknown variables which may affect the outcome, thereby forming the basis for our statistical tests. So what are the types of randomization? It can be broadly be divided into simple randomization and restricted randomization. By simple randomization, we mean that each participant has an equal chance of entering either into the intervention or the control arm. By restricted randomization, we mean that allocation is controlled so as to ensure a balance either in group size or baseline characteristics or both. Restricted randomization can further be divided into block randomization, stratified randomization, or other adaptive randomization methods. So coming to the first, that is simple randomization. In this method, participants are assigned to a single sequence of random assignments. To do this, first, we determine the number of groups and then we apply an appropriate randomization method. The most commonly and preferred method which is used for simple randomization is through computer-generated random numbers. Alternatively, we could also use random number tables from statistical books, or we could also employ manual methods like tossing a coin or by rolling a die. It is important to avoid predictable or non-random methods for randomizing patients into either of the arms. For example, using a chart number or the date of birth of the baby, or by using alternating numbers of patients. The limitation of using simple randomization is that in studies with small sample sizes, sometimes it might result in an unequal distribution of numbers between both the arms, or it might result in an unequal distribution of covariates between both the arms. So this is a representative example of simple randomization. In this, we have participants who are numbered from 1 to 12. And we see that participant number 2, 5, 8, and 10 are eligible to take part in the study, and they have been randomized. Participant number 2 and 5 have been randomized to the intervention arm, and participants number 8 and 10 have been randomized to the control arm in no specific pattern or no specific sequence. So coming to the next, which is block randomization. In this method, participants are randomized within blocks of a fixed or variable size. The first step in block randomization is to choose an appropriate block size. And this is usually done based on the allocation ratio of the treatment and the control arms and the number of arms in the study. Usually block sizes of 4, 6, 8, etc. are used. So once we've made an appropriate block size, we create all the possible permutations of patients for that block. So this is a representative example. So this, in this example, we have a block size of 4 patients, and these are all the different permutations of patients which we can have in each of these blocks. So once we do this, we randomly select a sequence for each block, and then we go on to assign the patient sequentially. The advantage of block randomization is that it ensures equal group sizes at all times. However, the drawback is that we might be able to predict the allotment of patients. For example, say we have a block size of 4 patients and 3 of the patients have already been randomized, of which 2 have been randomized to the intervention arm and 1 has been randomized to the control arm. Now, since we know that it is a block size of 4 patients, the 4th patient who is now going to be enrolled will definitely go into the control arm, thereby creating a possibility for selection bias. This can partially be reduced by using blocks of varying sizes. Also, block randomization has increasing complexity when it is done with more arms, and it does not control for prognostic factors. So what would a block randomization look like? This is a representative example which was created using the sealed envelope website. Say we have 2 treatment groups, namely group A and group B. And in this study, the investigator wanted to create blocks of variable sizes of 4, 6, and 8, and he had a total of 50 participants in the trial. So the first patient who enters the trial would be allocated to the first block. He would be the first sequence within the block, and he would go to group A. The second patient of the first block would go to group B, and so on. So coming to the next, stratified randomization. In this method, participants are divided into strata based on important patient characteristics, and then they are randomized within each stratum. The first step is to select a few stratification variables, for example, gestational age, center of the study, etc., that can influence the outcome. And then we go on to create subgroups based on the categories in these variables. Within each stratum, now we would randomize the patients, and at the end, we would combine all the data for analysis. The advantage of stratified randomization is that it creates balanced groups with respect to baseline characteristics, thereby improving the power by reducing variability within key factors. The drawback is that it is a complex process which is difficult to implement, and when several stratification criteria are employed, there is a risk of over-stratification, thereby resulting in unbalanced groups and loss of power. The last, which is adaptive randomization, includes all those methods that allocate participants into either of the groups, either based on previous assignment of participants or based on the outcomes of the participants who've been allotted to either of the arms. Commonly, the method of minimization is employed, in which whenever we have a patient who is eligible for randomization, the algorithm would calculate the degree of imbalance that would occur if the subject was assigned to either of the treatment groups. The allocation which produces the least imbalance is then chosen and the patient is assigned to that particular group. The advantage of adaptive randomization is that it produces balanced groups in terms of covariates, and it also allows for more covariates to be taken into consideration in contrast to a stratified randomization. However, it is complex and it cannot be done forehand. Now that we've seen randomization, if we know into which group our patient is going to be randomized, it could influence our inclusion or exclusion of the patient, thereby resulting in selection bias. So that brings us to allocation concealment, the purpose of which is to ensure that the person enrolling and the participants do not know the upcoming treatment. In case allocation concealment is not done, it could result in overestimation or underestimation of the treatment effect, thereby producing heterogeneity in results. So the methods for allocation concealment include central randomization, in which a recruiter calls a central service or uses a secure system after enrollment, and this often requires a mechanism for contact and thorough training of staff who are manning the central randomization office. Other methods which are acceptably used for allocation concealment are sequentially numbered opaque sealed envelopes, which are tamper-proof envelopes, which are opaque, that are sequentially opened only once a patient has been enrolled into the trial and the patient details are written, and it often includes a pressure-sensitive paper for audit trail. Other methods include sequentially numbered containers. These are similar appearing containers of equal weight which are tamper-proof, or it could be pharmacy controlled where the researchers instruct the pharmacy in allocation concealment. So this is an image of a study which was done at AIIMS. This is from a crossover blinded study where ocular drugs were administered to neonates. So if you look at the image on the left, which is E1, this is the drug which is administered for the first time, that is E1, and the patient is from the first sequence, and 20 is the patient's serial number. E2, the image on the right, is the drug which is administered for the second time in the first sequence, and 20, which is the serial number of the patient. So during allocation concealment, it is preferred that the person who generates the allocation sequence should not be the person who determines the eligibility and entry of the patients. And if possible, the mechanism for treatment allocation should use people who are not involved in the trial. It is not acceptable to use predictable sequences or transparent envelopes for allocation concealment. So lastly, coming to blinding or masking, it refers to keeping the people who are involved in the trial unaware of the assignment of the patient. This will help in controlling two major biases, namely performance bias and ascertainment bias. The people who are blinded in the trial could be the participant, the research investigator, the outcome assessor, or the data analyzer. Based on the people who are blinded, it could be an open label trial, a single, double, triple, or quadruple blinded trial. By open label, I mean that nobody is blinded in the trial, and by quadruple blinded, I mean that everybody who's involved in the trial is blinded. Sometimes, however, blinding is impossible either because of ethical, technical, or methodological considerations. In a study, it is important to clearly state the status of blinding and also explicitly state the people who have been masked in the study. So to conclude, to control for confounding variables which would arise in the pre-randomization period, randomization and allocation concealment are useful and they would help in preventing selection bias. And to control post-randomization variables, blinding would be essential, and this would help in preventing ascertainment bias. So coming to our study, babies who met the eligible criteria were in a center. The details of those babies were then informed to a central randomization unit, where these babies were stratified by the center and according to the two gestational age groups, and the pharmacist of the center was informed to dispense numbered bottles. So patients who were allocated to the intervention arm received enteral caffeine citrate at 10 mg per kg per dose of caffeine citrate given daily during the course of hospital stay up to 28 days after discharge. And patients who were in the control arm received an equal volume of placebo that contained all the components except the caffeine citrate. The objective of the study was to evaluate the effect of continuing treatment with caffeine citrate in hospital and at home in moderately preterm neonates with resolved apnea of prematurity on the days to hospitalization after randomization. The primary outcome of the study was the number of days of hospitalization from randomization to discharge up to 48 weeks PMA with censoring at the time of transfer or death. The study also had several secondary outcomes, which included the number of days of physiological immaturity, which was defined as the number of days the baby was stable being outside an incubator for more than 48 hours, the number of days it took for the baby to remain apnea-free for 5 days, and the number of days where the baby had a steady weight gain on feeds of greater than or equal to 140 ml per kg, postmenstrual 8 at discharge, up to 48 weeks PMA, the number of all-cause readmissions, including apneic events and acute life-threatening events, the number of all-cause sick cause visits within the first 8 weeks after discharge. It also included several safety outcome measures which were measured prior to the baby was being discharged, which included weight gain, tachycardia, high blood pressure, use of anti-reflux medications, apnea or bradycardia, arrhythmias or seizures, and death. Interim analysis was planned for the study at 25%, 50%, and 75% enrollment once they had completed a follow-up of 8 weeks. The study also had a pre-specified futility threshold of less than 15% conditional power to detect a statistically significant effect. So, once we had randomized a baby to either the intervention or the control arm, caffeine or placebo was started, and the babies were followed up till discharge for physiological immaturity, recurrence of apnea, weight gain, caffeine side effects, postmenstruated discharge, and mortality. In case the baby had a recurrence of apnea, it was managed with open label caffeine therapy or with respiratory support initiation, during which the trial drug was suspended. Once there was a resolution of apnea, the trial drug was again reinitiated. After the baby was discharged, the baby was followed up every weekly for the first 4 weeks, and both the arms were given either caffeine or placebo up to 28 weeks after discharge. Between the week 5 to week 8, babies were followed up bi-weekly, and after discharge, the babies were followed up for a duration of 8 weeks where they were monitored for readmissions, apneas, or acute life-threatening events, and the outcomes were assessed. The study investigators assumed that babies who received prolonged caffeine would have a median difference in the duration of hospital stay of 2 days. That is, there would be a reduction in the duration of hospital stay from a probable 14 days to 12 days. So with a 90% power, a significance of 0.05, and an attrition rate of 5%, a sample size of 1,174 neonates was calculated. However, the study sample size was modified due to delay in enrollment due to the ongoing COVID-19 pandemic and because of approaching drug expiry. So the power of the study was reduced to 80% and the sample size was recalculated as 878 neonates. Coming to the results of the study, a total of 6,600 neonates were screened for enrollment, of which 3,900 neonates were found to be eligible. Among the 3,900, about 3,100 babies had to be excluded due to various reasons. Subsequently, 827 neonates were randomized, of which 416 were randomized to the caffeine arm and 411 were randomized to receive the placebo. Among those who were randomized to receive the caffeine, 25 neonates did not receive the intervention, and among those randomized to the placebo, 14 did not receive the intervention as randomized. After discharge, 31 were lost to follow-up in the caffeine arm and 35 were lost to follow-up in the control arm. And a total of 416 neonates who were initially randomized to the caffeine arm were included in the primary analysis for the treatment group and 411 in the control group. Therefore, the analysis was an intention to treat analysis. Coming to the baseline characteristics of both the study groups, the median age of the mother in both the groups was about 30 years, and most mothers were second gravida and second para. Coming to the characteristics of the neonates, there was an equal distribution of male and female babies between both the groups. The median gestational age in both the groups was about 31 weeks, and the median birth weight was about 1500 grams. The postmenstrual age at randomization was about 34 weeks in both the groups, and the weight at randomization was about 1900 grams in both the groups. This means both of our groups were almost similar prior to the analysis of the outcomes. So coming to the primary outcome, which is the median number of days of hospitalization, this was 18 days in the extended caffeine group and 16.5 days in the placebo group, with no difference in medians or risk. Coming to the secondary outcomes, there was no difference in the number of days to physiological immaturity between the caffeine group and the control group. And there was no difference in the number of days to release from an incubator for 48 hours and for baby to grow on feeds of more than 140 between both the groups. However, it can be seen that in babies who received caffeine, the number of days to being apnea or bradycardia free for 5 consecutive days was significantly lower in the caffeine group of 6 days, in contrast to the control group, which was 10 days. Looking at the other in-hospital outcomes, they had also looked at the weight change from randomization till discharge in both the groups, and babies in the caffeine group had a lower weight gain of about 3 grams per day, in contrast to the babies in the control group. We also see, in terms of the side effects, that babies in the caffeine group almost had a twice higher risk of having tachycardia with a heart rate above 200 in comparison to the control group. There was also a significantly lower number of episodes of apnea or bradycardia in the caffeine group compared to the control group, as expected with caffeine therapy. Looking at the post-discharge outcomes, there was no significant difference in terms of all-cause readmissions or all-cause sick visits or any sick visits related to apnea or ALTE events. Though we had previously seen that babies in the caffeine group had a slightly lower weight gain, it was seen that weight change from randomization until 8 weeks discharge was not significantly different between both the groups. So the strengths of the study are that it is a large, multi-center, placebo-controlled blinded trial, which was done even in the COVID-19 period, which was methodologically sound with a rigorous follow-up. However, there are a few points to ponder. In terms of the population which was selected, the median gestational age group of the population was 31 weeks. And based on a clinical experience, we often see that these babies often have feeding issues which are slightly more important than the apnea issues. Also, the study had about 3,900 eligible participants, of which a large number of patients were excluded due to consent reasons, which is about 3,100 neonates. Coming to the intervention, the authors reported that a dose of about 10 mg per kg was probably insufficient in showing a significant difference between resolution of apnea. However, a 10 mg per kg dose was the upper limit in the CAP 2006 trial. And also in this trial, the same dose has been shown to reduce the time to apnea resolution by a median of 2.7 days. So unlikely that this dose was insufficient. And also with the prolonged caffeine therapy, predictable adverse effects were also encountered. In terms of the outcome, an earlier reduction of apnea did not translate into earlier physiological maturity. And though the time to apnea resolution was reduced by 2.7 days, there was no difference in the duration of hospitalization, thereby probably indicating to us that oral feeding is a more important determinant for hospital discharge in this age group. The authors also reported that open label caffeine therapy could also have probably led to a reduced effect size in both the study arms. However, the incidence of open label caffeine therapy was less than 1% in the caffeine group and only 4% in the control arm. So in resource limited settings like ours, use of prolonged caffeine therapy would significantly increase the hospital costs or the patient costs. And as seen in this study, where the adherence was 70 to 80%, despite having rigorous follow-up, we will not be sure of the real-world adherence of prolonged caffeine therapy. Also, neurodevelopmental outcomes could have been included in the study. So the study concluded that in 29 to 33 weeker neonates with resolved apnea of prematurity, continuation of caffeine beyond discharge does not reduce the duration of hospitalization or readmissions to apnea. After the study, we could probably do a study in a lower gestational age group, say less than 28 weeks, where prolonged apneas are a major problem. And we would also need further studies to assess the role of home caffeine therapy. Thank you.
Thanks, Arshita, for a wonderful presentation. And I would straight away invite Dr. Woli Carlo for his comments.
Thank you very much. So great to be with you all today. And thank you to Harshita for excellent presentation and accurate review of the study. So a few comments. So the pronunciation, Ramesh, is Mocha, like in the caffeine drink. So actually, it was one of my fellows who named the trial. He's pretty witty. So, but it was a big effort. One thing is, we knew that getting to full feedings delayed discharge, and in general, in many studies, both getting to full feedings and getting apnea free are the two main reasons why babies have prolonged hospitalization. So, because in a large study, Dr. Eric Eichenwald, found that there was an association of getting to full feedings at the same postmenstrual age of getting apnea free. And he had postulated that there would be association of those. We tried to see if we could reduce also the time to get to full feedings by the use of caffeine, because it would be breathing better, not becoming apneic during feedings, for example. So that's the reason for the design. We use a good dose of caffeine, 10 per kilo of the caffeine citrate. But there's some evidence that a higher dose may be better, but not really tested so well at this gestational age. So that's an important consideration. But as Harshita mentioned, there was a pretty large effect, 2.7 days. We had postulated 2 days, so we were not way off. But unfortunately, getting to full feedings also delays discharge and confounded the benefits. We on purpose wanted to have time to discharge as the primary outcome because we knew and we were expecting an effect of apnea. So in a way, we designed the study to look at an important outcome that would not be biased by just the caffeine administration. It would have a clinical impact. I think, as Harshita mentioned, a younger gestational age cohort may have been a good idea. Those babies do have more apnea at later gestational ages. And the reason for not doing this is because we didn't want to confound with many other problems that extremely preterm babies have. And they're also included in many trials in the neonatal research network. So it's more difficult to do a study like this one late in the hospitalization when the babies would have been enrolled in other studies before, and according to our usual guidelines are not eligible for a second trial at the same time within the same network. I'm not saying that there's never 2 trials at the same time, but we try to minimize the overlap between 2 trials. So So to summarize, it's a large trial. It's a practice that has been common. If you look at the paper and other studies that we reviewed here or reviewed elsewhere, it's a common practice. Maybe in some countries, 25 to 40% of the physicians prescribe it at some time. Doesn't mean that so many patients get the indication, but at least physicians, a substantial proportion of physicians use it. Caffeine has been used after an ALT event, not in the randomized control trial, but in 250 neonates who came back into the hospital. They were sent home on aminophylline, actually, and they did not have another episode, but it was not a randomized control trial. It was just observational study. So there's some evidence that the intervention works. I think a more selected population, for example, and in your environment, it may be possible that patients are already on full feedings. I love the paladine feeding. I've been trying to teach in the US how you all are experts feeding premature babies. So in that environment, it may be a possibility, especially after apnea prolongs hospitalization a lot. So I think it's a possible intervention in the future. I think more research is needed. Harshita mentioned the ICAF trial that was presented at PAS 2 years ago. And that one showed that it reduced lengths of stay, but that was not the primary outcome. That was an exploratory outcome. So I think more evidence is necessary. It would be helpful to make a more informed decision of patient care. So as was mentioned before by Ramesh, we're trying to individualize patient care. And I think this is the future of neonatology, in which we're going to try to individualize care to improve outcomes. Thanks for the opportunity to be here. Thank you for the invitation, Amit and Ramesh. Thank you. It's great to be here with you all today.
Thanks,
Thank you, sir.
Wally, for wonderful comments. And over to Dr. Dutta.
Yes, sir.
Yeah, thank you, Ramesh and Amit. And thank you, Wally, for giving that wonderful overview and putting everything in context. It was, I think, a fantastic manuscript, and also extremely well presented by Harshita, who covered almost every point that needed to be covered. Since I see still very few questions in the chat box, what I'm going to do is I'm just going to share a small PowerPoint presentation and take up a few more very nuanced teaching points from this presentation. With your permission, Amit, just for
Yes, sir.
2 or 3 minutes. Are you able to see my screen?
Yes, sir.
Yeah, so Harshita has already very nicely covered the issue of randomization. I'm not going to go over it all. There was just one little nuanced point that I want to bring up, because we in neonatology, face this more than in any other age group, and that is the issue of multiple births. What do you do with them? How do you randomize them? And there is an issue of multiple births being randomized separately. And that's because multiple births are not independent. I mean, twins, triplets, they share genetics, they share intrauterine environment, shared breast milk, shared maternal covariates. And as a result, outcomes among multiple births, that means among twins, triplets, or quadruplets, are likely to be more similar, and the word used is, clustered, than outcomes of unrelated infants. And what that does is it reduces the variability, in statistical jargon that's called standard error, and falsely narrows 95% confidence intervals. So there are some solutions that have been proposed in the literature. The first is exclude multiple gestations altogether, but the trouble with that is that it reduces generalizability, and it becomes more difficult to achieve the sample size. The second is you treat the mother as the unit of randomization. That means multiple gestation infants all end up receiving the same allocation. But the problem with this is that you know that there is going to be clustering of outcomes. So the sample size then needs to be inflated in advance to account for this known clustering that's going to happen. The third is for twins, specifically randomize them 1:1 in the two arms. That means one twin goes to one arm, the other. Whenever you have a pair of twins, this at least doesn't takes care of the problem of clustering. But the problem that arises is with allocation concealment, because if you know that one twin is going to one arm, invariably the other twin has to go to the other arm. So allocation concealment becomes less unpredictable. And the third is individually randomized, which is what this study had followed. It is the simplest. A lot of people use it, but from a statistical point of view is the least desirable, especially if there are many multiple gestation babies. And then finally, in the if you do it, the analysis needs to account for that clustering. So in this study, we did have a number. The number of multiple gestation is not really mentioned in the table of baseline characteristics. Maybe Wally, you can throw some more light on this. They were individually randomized. And at least in the analysis, I was not able to find any mention for adjusting these multiple gestation. I'm not going to cover concealment of allocation blinding. They've already been very well covered by Harshita. Just a few points regarding the outcome. So this was what was mentioned about the primary outcome in the study. It said the primary analysis compared the number of days of hospitalization from randomization to discharge between the intervention and control groups with censoring at death, transfer, or 40 weeks post-menstrual age, whichever occurred first, using median regression with censoring, controlling for study, center, and gestational age group. And the outcomes presented are based on the median regression, but we assessed it at censoring in the median time to event survival analysis. Now, for beginners in the field, this may be quite daunting to understand what exactly this means. So I'm going to try and just unpack it for you. And it has a lot of nuggets of information and very interesting teaching points. And also shows how much the authors thought about all aspects of their trial before they actually planned it. So as we've been already told, the babies were born at 29 to 33 weeks. At PMA of 33 to 35 weeks, by the time by which one often considers stopping caffeine, they checked whether they met eligibility criteria for the trial. And in the intervention arm, they continued caffeine till hospital discharge. And they did not give caffeine, but they gave placebo till hospital discharge in the control arm. And then they give a further 28 days of caffeine at home after discharge in the intervention arm. And they continued placebo for another 28 days at home after discharge in the control arm. Now, it's important to remember that the primary outcome was a comparison of the duration of hospitalization after randomization in the extended caffeine arm versus the duration in the placebo arm. So it's important to appreciate that the primary outcome had nothing to do with the 28-day period of caffeine after discharge. So this 28-day period influenced only some of the secondary outcomes. So the primary outcome was influenced only by the decision to continue giving caffeine until hospital discharge. The authors were concerned that some patients may have died or got transferred out during the course of hospital stay, thus preventing the correct assessment of the duration of hospitalization after randomization. Because imagine if in the caffeine arm, you had more patients who were dying or getting transferred out, you would get the false impression that the duration of hospitalization was less in the caffeine arm. So this could have been a problem. And plus, the authors were worried that some infants may have stayed on for a very long length of time in the hospital beyond 48 weeks of post-menstrual age. And beyond that, the authors were really not interested in finding out the duration any further. So how did they handle this? The durations of hospital stay were likely to be skewed, so they were not able to compare the mean durations of hospital stay. They had to compare the medians. What they did was the primary outcome, that is the duration, was treated as the time to event. That means time to discharge after censoring. You saw that word censoring in the outcomes. For death before discharge, transfer out, and crossing 48 weeks post-menstrual age. So, they handled it a bit like how you do survival analysis. So out here, there's a curve. So imagine everybody, 100% are starting off being in the hospital. And every vertical drop out here against duration in days is an event. That means it's a discharge. Each vertical drop is a discharge till finally everybody gets discharged. And this is censored for death, transfer out, and crossing 48 weeks of postmenstrual age. What censored means is that those patients, they will contribute data till the point they die, get transferred out, or reach 48 weeks. And beyond that, they don't contribute any more information. So at least you don't lose all the information of somebody who has died or who's got transferred out. They still continue to provide information to the trial until that event. And beyond that, they get so-called censored. So authors could have compared the median time to event, that means the time taken for 50% of the subjects in that group to be discharged, but there was another issue that troubled them. And that was that the duration could be influenced by confounders. Important confounders was the center, because practices, including discharge practices, may differ, and the gestation. So likely, similarly here, it could be influenced by confounders. So putting all this together, they therefore decided to do what is called a multivariable median regression, which was mentioned in that primary analysis paragraph that I mentioned, adjusted for center and gestational age, and the duration censored for death, transfer out, and 48 weeks postmenstrual age. Median regression is very similar to multivariable linear regression, where the outcome is the mean of the outcome variable, whereas in median regression, it's the median. So basically, both of them end up looking like a formula like this. So at the end, the authors must have, the statistician in the study must have, derived a formula like this, which has the median duration is equal to a constant plus something multiplied by the group, plus something multiplied by the center, plus something multiplied by the gestational age group. So the group would be coded as 1 or 0. And ultimately, it is this coefficient which the group is being multiplied, which is effectively the difference in the median duration between the two groups. Because if other factors are held constant, with the caffeine, you get the caffeine duration by substituting group by 1. And with placebo, you get the placebo duration by substituting this group by 0. And then this beta 1 also has a confidence interval. That brings us to the primary outcome, which Harshita had shown. So as you can see here, this was the number of days of hospitalization, median, and the interquartile range in the extended caffeine and the placebo arm. Median was 18 here, 16.5 here. And these are the unadjusted median days, but censored for death, transfer, and postmenstrual age. Note that a crude unadjusted difference would have been 1.5 days, 18 minus 16.5. But when the regression analysis was done, the difference in the medians was actually 0. There was no difference. And that's because this 0 is after adjusting for center and gestational age. So it's different from the crude value. And the 95% confidence interval of the difference is from minus 1.7 days to plus 1.7 days. So this is the, the unpacking of that whole primary outcome, which I wanted to share with you. We can take up a few questions which are in the chat box. So the first question was, I think, addressed to Wally Carlo. Was it easy to take consent, sir, especially explaining parents that the baby would either get or not get the drug by random chance? I think that's a generic question, true for all randomized control trials that involve drugs. But Wally, would you like to take that specifically for this trial? How easy was it to take consent in this trial?
Sorry. Yeah, so sorry, my microphone stopped working. So, or my speaker, sorry. Okay. Can you mention again the question?
Yeah. The question was, how easy was it to take consent in this trial? Were parents concerned that, by random chance, the baby would either get this drug for, prolonged duration or not get the drug?
So, yeah, we got about 25% consent, and that's a little bit less than usually that we get. But I think the burden was high for these parents because they had to give a medication for a whole month. They also had to go home on a medication that was treating possibly treating apnea. And so most of the concerns were parents going through a study like this with their premature babies. It was not really that the parents objected to the study. They actually liked the study. Many times it was that they would rather go on caffeine home, which we have done in the past also. But in general, yes, it was difficult, but really it's because of the circumstances of having a sick baby in the neonatal ICU who is still having apnea. So it was not that that it was particularly upsetting for the parents or difficult for the parents to consent or not. Yeah.
Okay, there's another question from Amit Kumar. This is again addressed to Wally. Caffeine also leads to feed intolerance. So what is your view on the association of caffeine, probably prolonging the caffeine and possible feed intolerance? So could you address
So
that?
we look at that feeding intolerance. In our study, we report that as we agreed that the best way to assess real feeding intolerance would be being NPO for 24 hours. That was a criteria, pre-specified, agreed by all the centers. And that did not differ between the two groups. It was a trend for being better in the caffeine group. But the same observation was in the high-dose caffeine trial, in which also they did not find a difference in feeding intolerance. But that's a good point, and I think for the future, now we know that the best evidence now is that caffeine does not lead to feeding intolerance in these infants at this age.
Yeah, thank you for clarifying that. I think there are a few questions which are all related, and they were, what were the discharge criteria? I mean, were there standard discharge criteria that everybody had to follow across all centers, or was there some flexibility or leeway, left to individual centers?
So as a placebo-controlled trial, you don't have to have strict criteria that has to be followed. That's what we did is that each criteria. So the sites were free. They had to submit their plan for discharge. It had to be discussed by the whole group and not really approved, but understood why it was followed. Again, as a randomized controlled trial, that it was not a problem if some centers differ a little bit. For example, if you look at the data carefully, some patients were discharged soon after randomization, which really meant that they were not waiting the 5 days to 10 days that people said they usually wait when stopping caffeine. So in individual patients, there are other issues that they may decide to send the baby home earlier. And just a few comments, Dr. Dura, because your review was excellent. Exactly the thought process that you couldn't be explained better. I think you explained it better than what I would have done. But it shows also the complexity in trying to do a really well-designed trial.
Yes.
It's very difficult to do, but it's a pragmatic trial. Interestingly, a few things that are really interesting is that when we did the study, infants who went home on caffeine usually went home on a monitor, but a monitor could have biased the parents or the clinicians. So we decided they had to go home without a monitor. So some parents objected to going on caffeine without a monitor, and that's one of the reasons for refusal.
Yeah, that was one of your exclusion criteria. Yeah.
Yep.
Yep.
Mm-hmm.
Yep.
Yep.
Yeah. Okay. There are a few more questions. If we discharge the baby on caffeine, that's of course assuming that you are going to discharge, because this study doesn't really say that it changes the duration of hospitalization. For how long should we continue it, as parents may not be aware of mild apneic episodes, if any?
So we did 4 weeks, and that's based on how long it takes for this control of breathing to mature. It's still unclear. But for example, for research, we're doing sleep studies, and we show that at the time of discharge, there's still a lot of respiratory instability. Depending on the criteria that are used, most of the babies preemies at the time of discharge fail the sleep studies. And then we follow them at 3 months, corrected age, and almost all have resolved the problem. So, we try to balance the evidence of respiratory instability and not impose on the parents a very prolonged period of being on caffeine. We wanted to see if they could affect hospitalizations or emergency room visits. It did not. So I think it's a balance of trying to apply the evidence, but the balance of what could be done and what is acceptable for parents.
Yeah. The next question is, in a future trial on babies at a lower gestation, how can the confounding by feeding be taken care of? I'm not sure whether I've understood it correctly. And can a different primary outcome, like the number of apneas, be more fruitful than, I guess, in comparison to, say, duration of hospitalization? I guess that's what is meant.
Yeah, so the feeding issue, that's really context specific. In some places, they send babies home on cup feeding, or you probably send kids home, I assume, on paladay feeding. I don't know, but in some places maybe. In many of the hospitals where we did the study, in most of the hospitals, they require full PO feeding. And that was the criteria for this study. But in other circumstances, it may differ if you send babies home on other methods of feeding. And you mentioned a second question, and I forgot.
Yeah, so the question was that would having a different primary outcome, like the number of apneas rather than the duration of hospitalization, be more fruitful? I guess, again, to take care of this issue that your duration of hospitalization may be dependent on other things like feeding and so on. Would changing the primary outcome be more fruitful?
So, no, when you're trying to come up with an outcome, ideally for a large trial like this, you want to come up with a very important outcome, So we thought 2 days of hospitalization, let's say for 28 days at home on caffeine, may be a good balance. But just having less apnea is not really an important outcome, important enough, when we know it's so strongly linked to the intervention. So one thing is that when you have an intervention like caffeine that is so strongly linked to desaturations or apnea, then your primary outcome may be best not to do it like that. That's okay for a pilot study, for a small single-center trial, but it's really not ideal for a large multi-center trial where you're trying to change the needle, change recommendations of practice. In most centers, if you say, well, it didn't affect the hospitalization duration, but affected the oxygen saturation, you would not think that would be an important practice to change. So it's a balance of having an outcome that is related, but not directly related, immediately related, and is an outcome of major importance.
If I can take the liberty of paraphrasing what you said, Wally, I think what you're saying is that you all were looking for a patient-centric outcome or a parent-centric outcome, that it matters to everybody whether how long you stay in hospital, rather than having an outcome which was an intermediate towards that thing, the number of apneas that go towards. And there are many more things that affect hospitalization, which actually matters to patient, and you wanted to make a difference in that. Yeah.
That's correct. And this is similar to the earlier winning from the incubator that Sita Shankaran led in the network also. Yes, we could get the babies out of the incubator earlier, but that didn't affect the time from randomization to discharge. So this is a similar issue here also. I'm eager to do an intervention with oral feedings, and actually I'm eager to send some of our nurses to you So you can teach them paladine feeding so they can go home on paladine feeding.
Wally, the next question, I don't know whether you can see it on your screen. It's in the question and answer QA box. Is something that had troubled all of us when we read the paper, but I guess it was more of a typographical error. And maybe you can go back and see it. So what happens is in your paper, in the consort flow of the trial, it is mentioned that there were a large number of exclusions due to planned discontinuation of caffeine, having reached more than 120 ml per kg per day, being able to start medication less than 72 hours, being between 33 to 35 weeks of randomization. But really speaking, these are inclusion criteria, not exclusion criteria. And I was just wondering whether there's a typo somewhere in the paper. Maybe you intended to say not being planned to discontinue caffeine, not having reached to 120 ml per kg per day, and not being able to start medication in less than 72 hours. I think it's probably just slipped through the cracks somewhere. So maybe you could just...
So we have two lists. You're right. The first list is for inclusion criteria. So they did not meet inclusion criteria. That's the issue.
Probably are not there, because it does get a little confusing when you read it. Okay. So there's the next question is randomization was stratified for gestation and center. So what was the need for the regression adjusting for these two? And this is a methodological issue. And if it's okay with you, Wally, I'll just take this question up. So yes, this is a mandatory requirement. Even the consort and all regulatory authorities say that you have to adjust for variables for which you may have stratified. And the reason is that there is still some residual variance even after stratification that may remain in things for which you stratify. So stratification is not a panacea. It's not a magic thing that will ensure absolutely identical. And usually you stratify for the most important potential confounders. So therefore, it is important to adjust for these stratifying variables in the regression. You may opt to adjust for some more variables apart from the stratifying variables, but they all have to be pre-specified in the protocol. They're not something that you come up with after you've received, your data. It should not be data-driven, your adjustment. It should be all pre-specified. They should be biologically plausible before the study had started. Okay. The next question.
You're right. And to highlight that, notice that we did not put statistical results without the adjustment. We put the raw data, obviously cannot be adjusted. So we put the raw data, but only reported the statistical analysis of the adjusted. That's the correct way to do it.
Yes. Yeah. So that final right-hand column had only the adjusted analysis if you read the paper. Okay. Now, here is a question. Won't the death censoring reduce the duration of stay? If there are more deaths in one arm, it'll seem to perform better. Well, that's precisely the reason why you do censoring. Because if you were to just take the crude number of days before death and total it up without going through this survival analysis approach, you will arrive at a wrong conclusion that the arm in which there were more deaths actually had a mean shorter duration of hospital stay. So what the authors did was absolutely right. And although Wally, later on, I'll probably have a one-on-one discussion with you, whether it was correct to include death as a censoring variable, because it's truly speaking a competing variable for the outcome. I mean, when death occurs, you cannot have the outcome. Which is, methodologically, there are some issues with that, but we'll discuss that later. I don't want to confuse people. So,
and it was only one death. It was after discharge.
So it doesn't really matter. Yeah.
It's in the caffeine group, but it was a car accident.
Okay. The next question is, does apnea resolution actually matter anymore if early apnea resolution doesn't shorten the hospital stay or reduce hospitalization? I think what the person is trying to say is that in the secondary outcomes, it has reduced apnea. So are we chasing a metric that no longer drives the primary outcome? So if your primary outcome has not been met, your secondary outcome, you have been able to show less apneas. So I think that's the sum and substance of the question. Should you still be recommending a longer duration of caffeine. I think that's what the person means. Yeah.
Yeah, I think at the present time, it should not be recommended based on this data and on these settings. You know, in other settings, it may be different. I know we're doing some research, and in other settings, we have a high mortality rate in premature babies after they go home. And we're trying to sort it out and see if it's from apnea or something else. So I think it also depends. The discharge age at these babies is pretty late. In other settings, babies are discharged more like closer to 33, 34, 35 weeks. So
yeah, Wally, even in India, we tend to discharge babies much earlier than what you do in the US, taking a risk. We're actually taking a risk all the time when we're discharging that early. And we're always worried, what will happen, suppose they have an apnea at home. And I don't know. So that's why the implications may be different for a country like, and we don't have apnea monitors. Nobody's ever discharged on apnea monitors in India. So
yeah, we're doing a study now. We're doing a randomized control trial. So if you want to join us, or we're interested in testing this. Yep.
Okay. The next question is, in this trial, caffeine supplementation was associated with decreased weight gain, decreased apnea, but no difference in hospital stay. So putting all these three things together, what do you suggest, say in a country like India, should we give oral caffeine or not after 33 to 35 weeks? So there was indeed a slightly less weight gain. That was.
Yes. So for discharge home, I cannot recommend it based on this data. In this type of population, it may be that other populations may benefit from it. Let's say babies who are on full feedings, that may be a difference. But based on this study, it cannot be recommended really. But it's important because the practice has been common in many places, in many countries. So I think the information is quite helpful.
Yeah, I think we are also running short of time. We're almost reaching 90 minutes. So I'll take up just one more question, maybe one or two. How did you ensure that the caffeine was actually taken at home? Well, in both the groups, the question out here is in the intervention group, but in both the groups, the parents must have been counseled that their babies actually did not need caffeine as per current practice, and 50% of the babies in the trial would anyway not get caffeine. So how did you ensure that they actually got the caffeine at home?
Yeah, so it's a pragmatic study. So we felt it would be better not to try to get serum levels. So that may be a limitation, but in the study that Eric Eichenwald presented, most patients took some medication. There was a significant difference, like zero. The level of caffeine was zero in the group, and then normally in the other group. So indicating that the overwhelming majority of the patients took the large number of doses. Obviously, in our study, not every parent gave all the doses, but there were instructions. If they miss a dose, that's okay. They can give the dose the next day. There were specific instructions on how to follow the protocol, even after they had missed one or two doses.
And I'll take up one last question, and that was, did you do a cost effectiveness analysis before you started the trial? What would have been the cost implications of prolonging caffeine versus the decreased cost of 2 days of hospital stay, which is, I think, an important question.
So that was considered for us, to do a study if it was effective. If it was not effective, obviously there's no point in doing a cost effectiveness analysis. Just would show cost only.
Okay. I think I'll end here. We've.
I had one observation and a comment, sir. Many a times, discharge in our place is not very well planned. At times, parents decide for discharge because of various reasons when the baby is still on caffeine, or just caffeine has been stopped a day earlier only. So, in such a scenario, when babies are high risk, we tend to send them home on caffeine because that duration of 5 to 7 days of caffeine free, apnea free caffeine is not being there in the hospital. So, we have been doing this for a reasonable time. And so, how would you rate that practice of sending home in such a scenario a baby on caffeine?
So we have the same issues here. I've been sending home babies on caffeine or before theophylline for years. And it depends many times on those circumstances that you mentioned. The mother wants to go home. We've been waiting days, and the baby still having occasional episodes. And we don't think the baby is sick, so we goes home on caffeine. Yep. So we still do it after this study. We are not doing it routinely on all patients, but we do it selectively depending on specific circumstances. Yeah.
Yeah. So with that,
And sir, yes, sir.
with that, Amit, I'm sorry I have extended the time period. I know you wanted to finish it in an hour, but there were, so many questions. I didn't want to disappoint people who had asked so many very valid
Yes.
questions. So I hand over back to you to wrap up the proceedings.
Yes, sir. Thank you, sir. It was an excellent session, and it really enthused the group to have many more sessions after this inaugural session, and having it right from the horse's mouth, from the lead lead author was really great, and it enhanced our enriched our learning, and it gave a big insight into the making of the study and implementation. And people like Dr. Saurabh, Dr. Ramesh, who are deep into trials and studies, they would also have learned a lot from your insight and your expertise, I'm sure. So thank you, everybody, for being there, for giving extra time to us. It was planned to be a 60-minute session, but it has ended up being a 90-minute session. We have about 200 people on board, which tells us how engrossing this entire session was. Thank you, everybody.
Amit,
And
maybe
a wonderful,
you could make an announcement of the neonatal research
yes,
methodology
sir.
workshop
Yes.
on
So, Dr.
30th and 31st.
Pratima, if you can show that we have a research methodology workshop coming over at end of August in Lady Harding Auditorium, and the flyers will be flown again. The date is 30 and 31st of August, over a Saturday and Sunday, with wonderful faculty who are experts in research methodology. They have been conducting this workshop for NNF for last many years, and we request all of you to join, help, let your PGs fellows join that workshop as well. And yes, and when is the next session, Dr. Saurabh? 28th of August?
28th of August, last
8
Thursday,
p.m.
8 p.m. Yeah.
by
We'll meet
Hyderabad group led by Dr. Veera Raghavan and his unit.
Yes, that's right.
So, and maybe we all will be there again. And thank you, sir. Thank you, Dr. Wali, especially for joining over from so far away, 7 seas away. And we'll have you as a co-chairperson. Sir can be there in our journal club as well.
Thank you so
Thank you,
much.
everybody.
Thank you.
Thank you, sir.
Okay,
Bye-bye.
thank you, everybody. Bye.
Thank you, Dr. Ramesh. Thank you, Harshada. Thank you, Dr. Bakhu.
Thank you very much.
Thanks to
Okay.
everyone.
Thank you, sir.
Thank you, Dr. Lalan.
Thank you. Thank you.
Dr. Somshekhar, if we can have this journal club as a an article in Journal of Neonatology, then it will be great.
I
We
think
can have the transcript, the questions, brief article
Questions.
followed by the questions and the answers which were there,
yes.
and a take-home message that will be of of good knowledge for the readers of your journal.
Sure. That would be great. Yeah.
Thank you, sir. Thank you, sir.
So,
Bye, sir.
bye, sir. Bye. Bye, Bakku, sir. Bye.